Hello everyone, this is Bob Browner. Recording an overview prior to our Tuesday afternoon to kind of set the stage for what we're trying to do with this REACH grant that you'll all be participating in. So the goal of this grant is to reduce health disparities on a number of measures in the next 5 years. We have 5 years of funding, which we can push out for you to hire your folks and try to make some of these things better. And what you'll see that is on most health metrics, there's different disparities based on ethnicity, and it varies based on each ethnicity, where sometimes, for example, uh, oftentimes Caucasians or whites are used as a baseline. Some ethnicities have better measures and some ethnicities has worse measures. And it varies based on health conditions. So this is for breastfeeding duration. It's sort of old data, but we're working on new WIC data that will be updated quarterly. We're putting together that with the health department and should have some baseline numbers to start with in about 2 to 3 months. But what you see is that the duration of breastfeeding is lower in some ethnicities versus others. Our goal is to make these disparities less prevalent in the next 5 years, or possibly even go away, which would be great. But we're going to keep measuring this over time each quarter and just see if whatever we can do can make these things better. We're going to pull multiple metrics. So the last one is breastfeeding. This is the percentage of school kids in Lincoln Public Schools will pass the FitnessGram Pacer test. So it's a measure of aerobic fitness, which has been linked to academic achievement and many other health benefits. And so we want these things to get better over time, but also for the disparities between ethnicities to also decrease. We'll have these measures every year. This is based on last year's data. I should have LPS data probably by March, I'm hoping, to see what is the most current measures on this and can we make them better over time. We have raw numbers, so we actually have measures on thousands of kids, so we have grid sample size to see if this is getting better over time. We're also working with clinics, so this is an example from one of our large safety net clinics in town. What this is the percentage of diabetics that are not well controlled. And you'll see very big differences based on ethnicity. And again, for this, we want to make this better over time. How can we work with your organizations to reach out to these specific ethnic populations and make these disparities in diabetes control better? One thing we've learned with our clinical quality improvement is you need to get a little creative and learn from everybody else, and that there's many ways to get there. There is not one magic way to make everybody healthier, and it's going to vary based on, at least in the clinic setting, it varies based on the staff that they have, the interventions they pursue, and what they can do, and it varies quite a bit from location to location how they get there. So what I tell people is I as a health person can't necessarily give you the magic work plan on how to get there, but I can give you ideas. What we try to do is we take a starting point where we basically say, okay, let's say our breastfeeding duration is 40%. By the end of this 5 years, maybe let's set a goal of trying to get everybody up to 50% breastfeeding to 6 months, for example. Well, how are we going to get there? Well, it's determined by a couple things. There's a whole bunch of different ways this could work out. First is you need to figure out who are the staff that are going to deliver this. Second, what are the interventions you're going to try? And lastly, it's going to, like the data shows before, the approach and the need is going to vary based on race and ethnicity. That's where your expertise hopefully comes in, because my background is a rural white kid, so I don't look at things the same way you do, so you will have a better idea of how to deliver your populations than I do sometimes. So staff roles, the two funded roles that we have funding for the next 5 years. One is a community breastfeeding educator role. The second is a community health worker role. These are the people that you'll have in place with different training. Then there's a lot of possible interventions, and we don't. It's going to be partly up to you to decide how you want to go about this. Is it something like community parenting classes, community home with health worker, home visitation, health promotion, working with other organizations like your churches or neighborhoods? You'll figure that out and you'll come up with your own plan. So you'll pick your two staff. So for example, you'll have your community health worker and a breastfeeding educator. You'll pick a couple interventions that you think will work. You'll deliver them through your cultural lens, and hopefully over time we'll see changes in outcomes. This is something, it'll be an iterative process, so our plan is to meet regularly to talk about this. We'll see what's working, share amongst ourselves. We'll have different ideas over time, and hopefully over time start seeing that these health disparities reduce over time. A couple other things to think about is that there's becoming a lot of interest in what's called the social determinants of health. And that's where there's a number of other things that you can measure from a health standpoint that people don't always think about that have a huge impact on people's health outcomes. One of them is food insecurity in the clinical setting. Why would food insecurity make a difference in people's health? It seems to be it's one of those threshold moments where if you're So your household economics reach the point that you can't afford dinner on the table tomorrow, everything else tends to go bad as well. It's the time where you may not be able to afford rent. It's the time where someone's lost their job. You can't afford medications. And so food insecurity seems to be one of those threshold measures where everything gets tougher. The second thing that from a social determinants of health that is really coming out is the effect of loneliness and lack of social supports. So for example, one of the safety net clinics we work with on another contract, they looked at the out of control diabetics they had in their patient population and found out that the majority of their out of control patients came from a household size of one. And what that meant was these are people who have no social supports, they're lonely, they don't much help. How can we fix that? Well, that might be the role for a neighborhood or community health worker approach to try to reach out to those people to try and improve their health status. There are actually structured measures for these things. So for example, there's a validated 2-question food insecurity measure that you can work with. This may be something we will think about in our community clinics, but also maybe at the neighborhood level, this is something you could maybe use for a screening instrument. But next steps, we're going to talk about this a little bit on Tuesday afternoon. We'll see what we come up with, see what ideas we have, and we'll start working on these things over time. We'll see you Tuesday afternoon, and hope you have some ideas.